Good morning. I am David Miller of Retina Associates of Cleveland in Cleveland, Ohio. Um, I'm also the medical director of the Cleveland Eye and Laser Surgery Center, and I appreciate this invitation from ViewMedi to discuss the risk of endophthalmitis following 25-gauge sutureless vitrectomy surgery period. This invitation was extended to me following publication of a paper recently in Ophthalmology Retina called Characteristics and Risk of Endophthalmitis Following 25-Gauge Surgery Over a 14-Year Period. Chase Miller is the primary author. I'm the corresponding author. Chase is my son, who's a medical student applying the ophthalmology, actually. And this was recently accepted in Ophthalmology Retina in November 29th, 2024. So I want to do a little bit of discussion about the risk and background of endophthalmitis and vitrectomy surgery, which was always thought to be not much of an issue in my field when I got into it about 30 years ago. But there's been quite an evolution of micro-incision vitrectomy surgery, in particular, MIVS, M-I-V-S surgery, sutureless surgery that's 23, 25, and 27 gauge systems. They offer many benefits such as reduced surgical time and faster recovery. The incidence and risk of endophthalmitis, though, ranges from 19 per 100,000 to 16 per 10,000. So you had a wide range of reported risk of endophthalmitis following these MIVS surgeries. And there's always been some concern that the smaller gauge systems may increase risk, in particular because it's sutureless and the wounds may be incompetent. So to give a quick overview of the importance of this study, it came out in the past year or two about the increasing rate of endophthalmitis and vitrectomy surgery. And one of the most impressive papers conducted in France with over 14 million procedures pulled from a public medical database showed that vitrectomy surgery was now the leading cause of endophthalmitis following ophthalmic surgery procedures. So back when it was cataract surgery at rates of 1 in 500 or 600, and then with the advent of intracameral antibiotics over the last decade or two, that rate's dropped dramatically as we see it today. But now with vitrectomy surgery moving the other direction and being sutureless or whatever the causes are, the rate for vitrectomy surgery has grown to being as high as 1 in 6 or 700 in this paper. And such that an editorial was written in Ophthalmology at the time by Dr. Su, calling it a wake-up call for vitreoretinal surgeons. I think there's still a bit of a denial process here about how common endophthalmitis is with vitrectomy surgery, because, even if it's 1 in 700, you're not seeing a case for most surgeons more than once every 2 or 3 years. But compared to the old rates published of like 1 in 2,000 or 1 in 3,000 before sutureless surgery, it is a significant uptick. So the significance of our study here is that this is the largest study to date on this topic. It evaluates the incidence, clinical features, and risk factors. It has a big benefit of being standardized across techniques, preparations, personnel, and platforms. All of these cases were pulled from one surgery center and one group of retinal surgeons. This is a retrospective cohort study conducted in our single retinal practice. We had 12 surgeons involved. And the study period runs from January 2010 to April of 2024. The sources of our data are my private practice, Retina Associates of Cleveland, which is now a 17-physician private practice dedicated entirely to retinal surgery and diseases, and the Cleveland Eye and Laser Surgery Center, which is a multi-specialty ophthalmic surgery center only, and we are the only retinal surgeons working at that center over its entire history, and including this time period. This gave us a lot of access to the numbers of cases, the types of cases, and the endophthalmitis cases with lots of detail since it's tracked at the surgery center and in the private practice. Data collected included age and sex, surgeon, first assistant, procedure type, etc., postoperative details, case length, vitreous substitute, complications from surgery, cultures, etc. We also looked at surgeon case counts, surgical platforms, did incidence calculations, statistics running a chi-square test for independence, and also some linear regression statistics to determine the association between case volume and endophthalmitis cases. As a separate cohort, we looked at all the cases done over a 2-month period, April and May of 2023, just to find out what is the percentage breakdown of vitreous substitutes when we finish a case. We use that to compare that to the vitreous substitutes in our endophthalmitis cases, and that was also analyzed statistically using chi-square testing. So to jump right to the results here, there were almost 25,000 total MIVS procedures, actually 24,987. We had 27 cases of endophthalmitis. All these cases were 25-gauge sutureless vitrectomy. How do we know that? This center only stocks 25-gauge vitrectomy packs during that time period, and all the surgeons used that exclusively. Our overall incidence rate then was 1 in 910, or 0.11%, mean age of 69 years. There's a male-female breakdown there. Most cases presented around 3 days post-surgical, and their vision before the operation was at about 20/80, and then with the endophthalmitis and waiting 90 days post-endophthalmitis, we ended up with vision at 2200. When we ran the statistics on the sex of the patients, we did not find that to be a significant risk factor at a p-value of 0.52. Quickly, just to take a look at the culture results from these endophthalmitis opposed to MIVS vitrectomy surgery. And the usual players show up, gram-positive, staph epidermidis, serratia is an unusual one with very poor outcome, gram-negative, as you'd expect, with the worst outcome. And the ones that did the best were the no-growth patients, recovering vision to a median of 20/60. So one of the first things we looked at was surgeons. Hey, we had 12 surgeons here working in the center. Is there something to do with endophthalmitis with surgical technique differences between the surgeons? And what we found is that there was no relationship between endophthalmitis cases and surgeon. We labeled the surgeons here A through L, and you can see the number of cases each surgeon had, and some of them may be higher, like Surgeon F had 7 cases of endophthalmitis here. But that surgeon also had the highest number of total cases performed at the center, 4,540. And the incidence there being of endophthalmitis 0.15. Some surgeons had 0 cases, but only had 877 cases total. So the relationship being that case volume going up also showed endophthalmitis cases going up in a linear regression statistical fashion with a p-value of 0.004. So the more cases you do, the more endophthalmitis you get, but there's no difference between the individual surgeons statistically that would make endophthalmitis more likely outside of the case volume. Then we looked at the procedure types. So in the center, over these 14 years, we broke the cases down by their CPT codes and to these 5 main categories. Macular pucker removal, 5,000 plus cases. Just straight vitrectomy for like a vitreous hemorrhage or opacities, 600 plus cases. Vitrectomy with endolaser, 588 cases. Vitrectomy for retinal detachment repair, 3,200 cases. And for macular hole, 2,400 cases. And then we have the endophthalmitis incidence rates for each of those. And you can see they're quite a bit different. Macular pucker at 0.23% being the highest, and RD repair and macular hole being almost 0. So we kind of wondered about the differences there, and that one of the things that strike us and the difference in these procedure types is, of course, the vitreous substitute. Macular pucker, vitreous opacity and hemorrhage, and vitrectomy with endolaser are commonly left under balanced salt solution, whereas RD repair and macular hole are almost exclusively left under gas or sometimes oil. So they get you an idea of those numbers and what it means in terms of your relative risk if you're doing a case or the number that cause harm. And a straight vitrectomy, about 1 out of 660 cases, it could result in endophthalmitis. And a macular hole in comparison, 0 out of 2,414. But again, the cases left with liquid media, valent salt solution, have relatively much higher incidence rate reports than what you've seen in the literature previously for all vitrectomies when they're counted in total. So what's going on there? Why are you getting more infections in some of these procedures? Well, there's a variation in infection rates, possibly linked to surgical exposure and manipulation. The procedure type indirectly, though, does measure the vitreous substitutes. And we found looking at these procedure types and comparing them that we had a significant p-value of 0.0004 for vitreous surgery procedure type against each other for the risk of endophthalmitis. So we have a statistically significant finding of the procedure type and your risk of endophthalmitis. One of the queries we had was about surgical staining and infection risk in particular. When we looked at all the cases that were stained, which were macular pucker and macular hole cases using indocyanine green, we had radically different endophthalmitis rates at 0.23% and 0%, kind of suggesting that staining is not related as an endophthalmitis risk. So we went on to look at a comparison cohort done over 2 months in 2023, looking at how often we leave what vitreous substitute in the eye. And 42% of the time we leave a gas-filled eye, 38.9% of the time we leave a BSS-filled eye, 10% silicone oil, and 8.7% air-filled. And when we look at the endophthalmitis cases, 23 of the 27, are 85%, are associated with valent salt solution-filled eyes, one with gas, one with air, and one with oil, make up the remaining cases. So you'll see it here, looking at this graph, vitreous substitute used in endophthalmitis, and the blue bars represent the control cohort done over 2 months. And the most common is gas-filled, followed by BSS-filled, oil-filled, and air-filled. And for the endophthalmitis cases, overwhelmingly, it's the BSS-filled eyes getting the infections, gas-filled 1, oil-filled 2, and maybe air-filled was, oil-filled was 1 and maybe air-filled was 2. But again, the vast majority of cases, 23 to 27 here, were BSS-filled. So what associations did we find here? Significant association between the type of vitreous substitute does impact endophthalmitis development. We have a very low incidence with non-BSS-filled eyes. This calculated out using chi-squared to a p-value of 0.00003, indicating a strong association. The reasons, you could postulate BSS may be a more favorable growth medium for bacteria, or perhaps the BSS allows the wounds to leak more than the other agents, being a lower surface tension. We also, to move on, we also looked at the surgical platforms used because we had this opportunity. We had 2 different surgical platforms used exclusively in the first part of the period from January of 2010 to February of 2016. And then we moved to the Doric EVA system from March 2016 to 2014. And we did have more cases of endophthalmitis with the Doric EVA system, 23 of the 27 cases, whereas the Alcon Accura system only had 4 cases. The statistical significance was positive here with a p-value of 0.4, but we're not so sure this is entirely the platform versus other conditions during these time periods. So though this is, certainly statistically significant, we're not so sure cause and effect in this particular case. What we're really stating here is that there's a significant difference between these 2 time periods, and what else may have switched between these time periods besides the surgical platforms, for instance, could be the case mix. If we were doing many more cases with valent salt solution-filled eyes, and as a for instance, vitrectomy surgery for floater removal has become a lot more common, the endophthalmitis numbers would be higher in the second time period. So Summary of the findings here, the take-home messages, the incidence rate of endophthalmitis is certainly higher than what I think retinal surgeons are used to telling their patients or been reported previously. The rate at this center is 1 in 910, or 0.11% across all cases. Significant risk factors for endophthalmitis will be the vitreous substitute, being balanced salt solution being a much higher risk. The rate there is maybe as high as 1 in 650. The procedure type, also significant risk factor. So again, macular pucker and vitreous debris and vitreous hemorrhage, again, being around 1 in 6 to 700. And the surgical platform, perhaps, with the caveat there that it may just be the time periods. Things that did not have a risk factor for endophthalmitis was the patient sex or the surgeon. So what we decided here is that our endophthalmitis rate in MIVS cases is higher than the non-MIVS, being reported previously between 3 or 5 in 10,000. Procedure types and infection rates certainly vary, as well as the vitreous substitute. Why would this be? Well, there has to be an introduction of bacterial nidus into the eye to infect the intraocular space. This could often come from the patient's own flora, as documented in prior papers. Other possible routes of inoculation could be contaminated instruments or implants, surgeons or assistants, contamination of infusion fluids, lack of sterile prep or field, or incompetent wounds post-operatively. Since non-MIVS, sutureless vitrectomy surgery, minimally invasive vitrectomy surgery, and MIVS cases are virtually identical in every aspect of the surgery except wound creation and closure, the suspicion is certainly very high that it relates to the wounds. Possible influencing factors there could be differences in surgical instrumentation or fluidics and the trocar and cannula system, contributing to varying risk when it comes to the surgical platforms. We talked about the time periods being different, and further study could be done there to investigate that. We had no intraoperative complications reported in the initial surgeries resulting in endophthalmitis, so none of these cases, looking at the op reports of all 27, showed any mishaps during surgery. There was no break in sterile technique, though it's always possible one event may have been undetected. And again, we mentioned surgeon skill, at least in this study, did not seem to play a role in infection rates. So what things can we do to mitigate these endophthalmitis cases? Looking at the fact that vitreous substitute is highly linked to it, as well as procedure type, which is also kind of a proxy for vitreous substitute. Well, you could do a partial air fluid exchange. This has been discussed over the years among retinal surgeons as having a higher surface tension to help slow sclerotomies. Of course, the downside is it may result in a slower visual recovery, limited protective effect due to the rapid air absorption, and the air may not cover the inferior sclerotomy site effectively when the patient's upright. When we look at our cataract cousins out there doing eye surgery, we know that intracameral antibiotics are very effective in reducing endophthalmitis rates. But we have concerns about whether these antibiotics could be toxic in the posterior segment, especially in a non-aqueous filled eye. And future studies could look at this. In particular, intravitreal antibiotics used prophylactically may be beneficial in balanced salt solution filled vitreous cavity. So, quick conclusion of the take-home points. The infection rate is 0.11%. Risk to infection, vitreous substitute, and procedure type, which again is a proxy, I think, for vitreous substitute, and surgical platforms, a possible risk, and surgeons and patient sex are not related. So a few limitations in this research we did, of course, is its retrospective nature, the low incidence of endophthalmitis, and challenge of detecting statistical significance in such small incidences. Future research recommendations would be like a prospective study exploring factors or mitigation risk strategies. Use of smaller sclerotomy sizes, for instance, 27 gauge, may lower that risk of wound contamination of the intraocular contents. Overall, endophthalmitis post-MIVS remains low, but we could probably look at changing our techniques or considering prophylactic treatments to get that number even lower. And I think we have to be aware that it's not as low as what it used to be. And I think there is a need here to change our techniques or procedures, because of the devastating outcomes of these cases, though they are few, it is very tragic for the patient, and of course, even the surgeon involved. Well, thank you very much for your time this morning. I hope you enjoyed this. You're more than welcome to reach out to me, and the article that covers this in more detail, again, is in Ophthalmology Retina online currently, and to be published in the print version shortly. Thank you very much.